My name is Rakesh Popat and I'm a haematologist from University College London in the UK. Here at EHA 2024, I spent some time talking about how we could use BCMA antibodies for patients with some challenging situations. And to that, we really focused on two specific cases. The first were patients who are more old and perhaps more frail, who've gone through 2 or 3 different rounds of myeloma treatment and have been exposed to the main classes. That's the proteasome inhibitors, the immune modulators, and the monoclonal antibodies. And what we were trying to talk about was they would be eligible for a BCMA-targeted treatment. And you have a choice of 3 essentially. You have belantamab mafodotin, which is an antibody drug conjugate, which is still being looked at in clinical trials. We have the bispecific antibodies, and we have CAR T-cell therapy. And really, when you're trying to work out which is the best treatment, you have to have a conversation between the healthcare professional and the patient to work out what the needs are and what suits the patient's circumstances. And I put forward a case where we had a 76-year-old who had diabetes and had some eye problems as a consequence of the diabetes, and was the main carer for his wife, who unfortunately had dementia. And this patient also lived a bit further away from hospital. And so in those cases, I think delivering CAR T-cell therapy might be a bit challenging because of the side effect profile. Antibody drug conjugates can be challenging as well, so really we want to be focusing on a bispecific antibody in this situation. And there you have to be mindful of the fact that teclistamab and elranatamab, which are the licensed antibody drug conjugates, require the patient to be in hospital for the initial phase, and then you deliver it on a weekly basis thereafter. And my recommendations would be that actually for an older and frailer patient, we'd probably back off a little bit and give the treatment in a less intensive phase, maybe giving it every 2 weeks and then going to every 4 weeks to make it more convenient and make it more tolerable for an older, maybe weaker patient, but also driving that response rate and ensuring that we're maximising the quality of life and the long-term survival for that patient. Now, the second case was a younger patient who had high-risk disease, had some kidney problems and had some myeloma growing in a lymph gland, which we call extramedullary disease. And for that patient, we would really want to give a CAR T-cell for that sort of patient. But the challenging aspect of that patient was that they had kidney failure. And it's really difficult to give CAR T-cell therapy to patients with kidney failure because we have to give a drug called fludarabine as part of the conditioning. And so we talked about different ways of giving the fludarabine. Maybe we could bring the dose down, maybe we could omit it, or maybe think of an alternative treatment. And again, the bispecifics can be useful there because they are very easy to deliver for patients with renal failure. But really what we're looking forward is for combination approaches for high-risk patients. And so there's some early data of teclistamab plus talquetamab, which are 2 different bispecific T-cell engagers, hit 2 different targets, and the data is really good for high-risk patients with extramedullary disease. And so we're looking forward for some more data to come out for that. But the bottom line is that even though the patients may be in challenging situations, I still think that we can find a path forward to give an effective BCMA-targeted treatment.